authors, I want to present our recent study regarding the accuracy and the performance of the PPG-based devices in blood pressure. I have nothing to declare regarding this study, and just want to make a small introduction. The introduction is nothing new, but I want to emphasize few things. We see the advancement in hypertension, yet I think that the main thing in the diagnosis of hypertension is still lagging. We see that in 2025, we don't have the technologies that can easily give us as physician the indication if the patient has or doesn't have a hypertension. We don't know what happens at the night if we rely on office blood pressure monitoring. We don't know what is happening exactly when we do ABPM monitoring in the cuff-based way. Thus, I still think that we need some better technologies to give us the confidence and the diagnosis of the blood pressure. And we saw here something before, and it's very important, but it's still the awake blood pressure. And during the 30% of the time that we are sleeping, we don't know anything. I want to emphasize also that the measurement of the cuff-based devices is still not very comfortable for patients. I want to choose very easy words. It has some patient discomfort, and we are not really sure if it does not change, elevate or lower the blood pressure that is actually happening inside the arterial system. So I just want to make sure that you know what I'm talking about. I'm talking about a device that is a PPG-based photoplethysmography. It's very similar to the smartwatches that we already have. And this device is patch-based that should be placed on the chest. This device connects to the mobile app, and it can measure the blood pressure, and we will see the results. It's very important to say that this device can measure up to 5 seconds frequency, but we use the measurements for this device according to what we see in the methods. We wanted to compare the blood pressure according to the most accurate blood pressure monitoring. So we know that it is not really the cuff-based measurement. And also the FDA suggested that we should compare the device with arterial line. Also arterial line, it has some limitations, but as you can see, it's the best available that we could ever have. So we had patients after heart surgery in the ICCU units, and those patients were routinely monitored by intra-arterial blood pressure, and we did a parallel monitoring for those patients with a BioBeat device. The BioBeat device was placed on the chest, and it did not interfere with the patient's decision and the data for the clinical and routine use. We recruited 96 patients. Among them, we had 32% females. And as you can see from table 1, the patient's population is very similar to the population that we usually treat also in our clinics and office-based. So the patient had obesity, diabetes, smoking, hypertension, as a previous diagnosis, ischemic heart disease, and etc. I wanted to emphasize that we did 2 different analyses. One analysis was all measurement sets. All measurements meaning we had around 80,000 measurement sets for the entire population. And we did the analysis in the 2 accepted methods. One is correlation, as you can see here, and the other is Bland-Altman analysis. And we can see that we had a very accurate and strong level of acceptance of the cuffless and the cuff-based measurements of blood pressure. We did also, and I can tell you something, that we don't really care what is the exact blood pressure in the second that we measured. We do need to interfere with the patients according to the patient's averages, as we already do in our clinics. So when averaging each patient and comparing the averages of the both systems, we see even a better result for the accuracy and for the level of acceptance. I will show you also that it's very important to make sure that we are tracking correctly the levels of the blood pressure, the systolic, the diastolic, and even the heart rate over time. Because if we do not see the trackability, we could think that the device just would guess. But in the ICCU patient, as you always know, there is a high interaction with the blood pressure in terms of medications that we use, the level of awareness of the patient, and as you can even see, the position. We did also what is called heat map. For each patient is just a column here, and we see the level of, or the frequency of measurements that fall within 5 units, or 10 units, or 15 units of acceptance, and we see that the heat map is very hot on the desired place. We did also stratify the patients on the color skin or color, we call it Fitzpatrick scale, which says something about the skin tone, and we see that the accuracy was across all skin tones. Additionally, we had different positions of patients. Of course, they were lying in the ICCU, some of them were intubated and some were aware, and you can see that those patients were lying on back, on left side, right side, sitting in bed or even in a chair, and we see that also the accuracy was across all positions. In summary, we again see that it was accurate and strong correlation between the blood pressure, systolic, diastolic, and heart rate, as we see in around 80,000 measurement sets. We see that it was reliable across all population in terms of skin tone. We see that it was reliable on different positions, and we see that it did track the blood pressure changes over time, and we had no drift. For me, the conclusion is very intuitive. I think that we need and we should have a better way to initially screen and further control the patients in terms of blood pressure. I personally think that the office measurements and the awake measurements are lacking, and the technology can aid on that. I just want to add, maybe it's the last slide, we need further personalization in blood pressure treatment. I think that we need a better screening strategy. I think that the standardization of the blood pressure measurement is still lacking. I don't see the blood pressure field as it happens in the diabetes and as it happens in other fields of medicine where we have the hemoglobin A1C, and we can no longer debate if the patient does or does not have blood pressure. We need to see what's happening at the night, and we want to know more about the blood pressure. We are 2025. We cannot rely only on systolic, diastolic, and heart rate for treating the blood pressure. We all know that there is cardiac output, there is systemic vascular resistance that is happening. We know that our medications act on systemic vascular resistance, which is very appealing to understand what's happening in that thing. We should know whether it's primary or secondary hypertension, and we cannot know anything about secondary or primary hypertension from only measuring the blood pressure per systolic and diastolic. And we want to further tailor therapy. We see all this place and all the conferences with many medications to cholesterol or to diabetes. But we don't have in the field of hypertension in terms of which medication to start or which technology to use in terms of renal denervation or other. Thank you very much.
Thank you.